Professor Mottram.
100.
Okay, chúng tôi sẽ we would like to speak in Vietnamese. Yeah. Chúng tôi rất là hân hạnh được lựa chọn tổ chức cái hội thảo liên quan đến cái thăm dò chức năng thông khí của phổi và trong chuỗi các cái hoạt động trong năm 2024 về việc cập nhật và kiến thức liên quan đến cái thiết bị, liên quan đến kỹ thuật, liên quan đến cái ứng dụng điều trị và chẩn đoán. Thì trong cái buổi hội thảo lần này thì chúng tôi rất là vui có sự tham dự của giáo sư Mottram, có giáo sư Lê Tuyết Lan, có các bác sĩ Quân và bác sĩ Tài từ các trung tâm hô hấp ở thành phố Hồ Chí Minh tham dự và trình bày các cái bài trong chuỗi các cái hoạt động liên quan đến thăm dò chức năng thông khí phổi. Và chúng tôi cũng rất là vui mừng được biết là có khoảng hơn 100 các thầy, các cô, các anh, các chị quan tâm đến lĩnh vực này tham dự online. Và trong cái con số đăng ký thì chúng tôi được biết là cũng hơn 30 người đăng ký trực tiếp, tức là offline, trong cả hai buổi, cả buổi sáng bắt đầu từ 8 giờ đến và buổi chiều. Thì trong đó có các bài thuyết trình về kiến thức liên quan đến lĩnh vực thăm dò chức năng thông khí phổi và hướng dẫn việc sử dụng các cái phương tiện thiết bị mới trong cái việc thăm dò chức năng thông khí phổi. Và chúng tôi cũng rất là vui có hơn 400 người tham dự đến từ các nước khác trên thế giới cũng đang online trong cái buổi họp ngày hôm nay. Và cũng trân trọng cảm ơn các công ty tài trợ đã hỗ trợ cho chúng tôi thực hiện được các cái buổi liên quan đến việc phổ cập và cập nhật các cái kiến thức liên quan đến lĩnh vực hô hấp. Và để cho thời gian hội nghị được bắt đầu đúng giờ thì chúng tôi xin trân trọng, sau đây chúng tôi xin trân trọng kính mời Professor Mottram with his presentation in pulmonary function test interpretation. Professor Mottram, please.
Good morning to everyone that is here, and good morning to everyone, or afternoon, if you're joining us online. It is my esteemed honor to come to Vietnam to give this presentation. Professor Lan, my host, has been inviting me for almost 20 years to Vietnam, and I enjoy the country, and most importantly, I enjoy the people. We're going to talk today about pulmonary function testing interpretation. That is the first lecture. I just want to reassure everyone that the measurement of lung function is very, very dynamic. There are many things that take place in the human body when we're looking at how deep a breath we can take and how we forcefully exhale that breath, and or how we measure other parameters by taking in either gas samples or having some other type of interaction with an instrument to characterize the lung function. Now, measuring lung function goes way back into antiquity, but Dr. John Hutchinson, a physician, is credited as being the first to use a modern spirometer to measure lung function. And he coined the term vital breath based on his analysis that the largest breath that we can take and completely empty out of our chest was linked to all-cause mortality. So he called it our vital breath. This was then turned into vital capacity. So that's where the term vital capacity comes from. He's also accredited for other terms associated with lung function, including residual air and other types of parameters. The link in between our vital breath and or our vital capacity continues until this very day. This is an article that was published in European Respiratory Journal, where it looked at the forced vital capacity related to other Framingham risk scores, and once again showed that that vital breath, the largest breath that we can take, regardless of what our disease entity or process is directly linked to all-cause mortality. So it certainly is that vital breath. Now, the American Thoracic Society and the European Respiratory Society are the professional organizations that write the technical standards on how to perform the test. Why do we have technical standards? Because we want to reduce variability. We want to increase the reliability, the precision and accuracy of the measurements themselves. And so esteemed colleagues gather, they look at the evidence that is currently published in the literature, and then they write a technical standard based on that evidence as far as how to perform the test to reduce variability. And the ATS and the ERS, by acronym as we like to call them, have been very busy over the last 10 years because they have either updated and or established new technical standards related to the lung function measurement. The last one, the lung volume update, was published in ERJ in October of 2023, and I participated in the creation and or review of that technical standard. So they also wrote a technical standard on interpretive strategies that was published in ERJ in 2022. They did not put the year, which is pretty common in their technical standards, in the title. They did most of the work in the years preceding 2021, but it was published in 2022, and so it is sometimes referred to as the 21 technical standards and or 22 because that's where it is referenced and published. There are also standards that come from the World Health Organization, and so we all know about the Global Lung Initiative for Obstructive Lung Disease and its key of using spirometry in the diagnosis and treatment and staging of COPD. We also know that in the same World Health Organization process, the GINA, the Global Initiative for Asthma, that spirometry and the results of a bronchodilator response are used to characterize and or stage or treat asthma. So even though we have these two World Health Organization initiatives, the overall use of spirometry in the diagnostic process is still underutilized. And so it's important to recognize that having objective measurements of either airflow obstruction and or responsiveness to a bronchodilator is key elements in understanding the disease process. So when we look at spirometry, we end up with, I'm looking at two different screens. When we look at spirometry, we have both the flow volume curve and the volume time curve. We typically hone in on or look at the flow volume loop, which was actually first described by one of my mentors at the Mayo Clinic, Dr. Bob Hyatt. His description of the flow volume loop did not occur until 1959. So previous to his description of this type of displaying of the spirometry results, there were only volume time measurements that one could look at. And we know that even though we kind of use the volume time tracing as an indicator of end of test, of plateauing, all of us perceive or use the flow volume loop in characterizing what we believe are certain patterns associated with spirometry. So it is the preferred methodology, and the loop portion, the inspiratory part of the flow volume curve, has been added as a quality indicator for making sure that someone takes a deep breath. So when we look at the algorithm, and I'm just going to refer to it as the 2021 interpretive strategies from here on out, when we look at their algorithm for spirometry, the very first branching point is the ratio of the FEV1 and the FVC itself. However, in the 2005 standard, they started out this algorithm with what about the quality of the test? And looking at the graphs, because looking at that flow volume curve can be very telling as to whether or not someone gave us a maximal effort when they were performing the test. So it's really important to start out your review of any test when you're interpreting the data at looking at the flow volume curve. And the flow volume curve assessment, even if you don't have all the measurements in front of you, even if you're at the bedside and you're just reviewing data, if you just go through these 4 little checkpoints, it will help you in understanding that the patient or subject gave you their best effort. One is the start of test. So is there any hesitation or anything else like that? So does it hug the y-axis? If the maneuver hugs the y-axis, then you can be assured that they started the test correctly. Then does it have a peak? Is the peak flow itself a nice sharp peak? Regardless if they have severe COPD or not, someone can generally create a very sharp peak of that flow during the maneuver. The only time that you may see a difference in that is if you have someone with neuromuscular disease, and sometimes younger children may create a more of a rounded part of their peak flow itself. But it's important to do that. Next is there any artifact or cough on the way down? Now that you can have artifact from the upper airway that is more associated with noise, and we won't dive into that in particular right now, but if you have cough in that first second, it's important to recognize that that's an unacceptable maneuver. And even if you don't have the volume time curve in front of you, if the flow goes all the way down to 0 on the x-axis, then you can be relatively assured that they exhaled all of their air. So when we do this, we end up with certain patterns, and the pattern of obstruction, regardless if it's very severe or moderate, is a concave shape to that flow volume curve itself. I like to make the analogy, not applicable to all diseases, but I like to make the analogy of a balloon. So if you take a balloon and you blow it up and you let the air out immediately, it comes back to its original shape and size. If you take that same balloon and you blow it up and then you let the air out several hours or days later, now you have a big floppy balloon, and the neck of the balloon collapses, and there is residual air in that balloon because it's lost some of its elastic properties, right? And so you end up with a big floppy balloon, and then that creates that flow limitation that you might see when someone exhales. So if the ratio is low, if the FEV1 over FVC ratio is less than the lower limit of normal, regardless of the circumstance, you have obstruction. So I always tell everybody, repeat after me, if the ratio is low, you have obstruction. And the obstructive pattern is most often associated with diseases like emphysema, chronic bronchitis, uncontrolled asthma, or ACOS, where you have a overlap syndrome. In this perfect Frank Netter cartoon, we can see the classic individual with COPD leaning on his knees, belt undone, cachectic, pursed lip breathing, clubbing, everything that you would associate with someone that has a emphysematous type-like picture. And that obstruction process is just like stepping on a hose, a garden hose with water flowing through it. The flow of the air comes out slower, creating that concave shape to the flow volume loop. Now, in the individual that has a restrictive disease, I also like to make the analogy of a balloon, but that's the inability of the lungs to take a deep breath, right? And there are many different causes as far as why someone cannot take a deep breath. It may be because of parenchymal disease, such as in idiopathic pulmonary fibrosis. It might be because of massive obesity, and because they are so overweight, they cannot take a deep breath. Their diaphragm doesn't work functionally correctly. It can be because of neuromuscular disease, or it can be because of chest wall abnormalities, pectus excavatum, pectus carinatum, scoliosis, kyphosis, anything that affects the cage of the body and then reduces its ability to take a deep breath can do that. In certain interstitial lung diseases, that inability to take a deep breath is just like that balloon, except for now we have a very small balloon. And if any of you have tried to blow up a very small balloon, it takes a lot of pressure because the elastic properties of that balloon are so great that it takes a lot of pressure to initially blow it up. The balloon doesn't get as large because it can't get as large, right? But that air pops out of there, right? It comes out very, very quickly. So you end up with very sharp types of peak flows, but very tented or smaller volumes. In other parts of the world, we celebrate Halloween as a fall type of activity for our children, and so I like to call this the pattern of the witch's hat. In certain circumstances, you can end up with rounded curves, and that's because of the inability to forcefully exhale. And this is the type of curve that we might see in someone with neuromuscular disease. They are so weak that they're in a wheelchair bound, and they cannot snap that air out very quickly just because, not of the lungs or the chest, but because they don't have the musculature to snap that air out. That's the only reason why you might see a more a rounded type of curve associated with a flow volume loop. So if the ratio is normal, so if the FEV1 over FVC is normal, you either have a normal test or you might have a small balloon or the inability to take a deep breath. And so the relationships in between how much air comes out in the first second and how much total air we can blow out is still in the normal range, but the volumes are small. So spirometry can suggest restriction. You need other types of parameters to confirm restriction. You either need the measurement of a lung volume by the various techniques that are out there, plethysmography, dilutional, washout techniques, and or you need an X-ray that confirms that they have small interstitial lung disease or something else. Spirometry suggests restriction or can be consistent with restriction. However, you need other tests to confirm that. And sometimes you end up with certain disease processes that affect both. So spirometry may be reduced and in the size of the volume, and it may be concave with the ratio FEV1 over FVC being less than the lower limit of normal. However, as I mentioned, you have to have lung volumes to confirm that abnormality. And there can be two reasons why the volume is reduced. It can be because the neck of the balloons have closed and you have air that cannot be blown out through the chest because the neck of the balloon has been closed. And so that would be like gas trapping that is still in the lungs but cannot escape the lungs. And or you can have a concomitant process. Someone that worked in a granite mine and had exposure to silica, so they ended up with a pneumoconiosis, but yet at the same time they were smokers and had COPD. So they can have concomitant abnormalities or coinciding abnormalities in a single individual, not just obstruction, but what we call a mixed pattern. But once again, you need lung volumes to reaffirm that. And then there are other types of abnormalities. We call these upper or central obstruction processes that affect the airflow themselves. So these can be characterized by something that's inside the chest, something that's outside the chest, and is responsive to or dynamic to the pressures that are associated with a forced FVC maneuver, and or something that is a fixed abnormality and affects the air both inside and outside of the chest itself. I like to characterize these as what's in is out is in. In medicine, oftentimes we use acronyms to help us through the process of remembering, and or we use mnemonics. And in this case, the mnemonic, what's in is out is in, is very helpful to us. If it affects the expiratory side of the curve only, then it's inside the chest. The abnormality is inside the chest. So that's a variable interthoracic obstruction. If it affects the inspiratory side of the curve only, then that's affected that's outside the chest, right? So whatever is happening is outside the chest, whether it be a goiter or a upper airway abnormality or vocal cord dysfunction or something like that, it's going to affect the inspiratory side of the curve because it's outside the chest. And then, of course, if it's a fixed abnormality, it's going to affect the shape of the flow volume curve on both sides, the inspiratory and expiratory side of the curves. There are also some other abnormalities. This is what is a normal variant, and so you end up having a flow volume curve that has a knee or a slight plateau at the beginning. So it's kind of like just putting your leg out here and having a knee, and that is a normal variant. It's called either a knee or a tracheal plateau, and it's created by the absence of flow limitation in the peripheral airways at high lung volumes. It is oftentimes seen more in younger women versus older individuals, but it is just a normal variant. So you will see a little bit of a knee, and that can be a normal variant. But then at the same time, if you see something that is extended much longer than that knee, then this is going to be the variable interthoracic obstruction, because it's affecting the expiratory side of the curve. If you see that plateauing of the inspiratory side of the maneuver, and they are giving you a effort, you can definitely see them giving you a good effort, then that would be consistent with a variable extrathoracic obstruction. In the new or newer 2021 interpretive strategies, They also looked at the FEV1 over peak flow ratio, and if that ratio is greater than 8 milliliters per liter per minute, that suggests a upper airway obstruction. So now we're going to switch gears here a little bit, and we're going to talk about what is normal or abnormal, because in the interpretation of lung function testing, you need to decide, what is normal or abnormal? What do I compare it against? And when we look at what happens in laboratory medicine related to urine specimen, blood specimens, and everything, it is very easy to, based on epidemiologic studies, understand what is normal or abnormal. The problem with people in general is that there is a lot of diversification in individuals and what is abnormal and abnormal. Blood is blood, but how we are as individuals may be based off of both economic and diet and social construct and everything else. So what is normal becomes a lot more problematic. However, it should be known that over the years, there have been many, many attempts to describe what is normal or abnormal. So in any given spirometer or lung function testing system, there is a plethora of different references that can be selected based off of the institution, the laboratory, or the medical director's description of what they would like to use. Now, these normals typically took place in the 1980s by a variety of authors, of which they are known for. But if you look at the variety of authors and the data that they were using, it was incredibly limited and oftentimes very limited to a certain population group, such as European-born Caucasians. So whether it be Crapo or Knudsen or Miller or the European Community of Steel and Coal, all of these published in the 1980s, they had very small numbers of individuals that did not necessarily represent a diverse population as we know is around the world. So the ERS, along with support from the ATS, put together a group called the Global Lung Function Initiative Group. GLI is the acronym. And in their mission was to gather information on a larger scale and apply scientific mathematical modeling to come up with better predicted values for individuals. And their first set was published in 2012 in ERJ, and it looked at the multi-ethnic reference values for spirometry across a large age range, 3 to 95 years of age. One of the problems with the other type of predicteds that were available was not only the limitation of the size and the limitation of the population diversity that they were looking at, but there was also the limitation of ages. And so you may have had an author that specifically tested children, and then you might have had other authors that specifically tested adults, and they did not connect very well. So you could end up having an abnormal lung function on a predicted set, and magically at age 18 switch to a different predicted set, and now you were within the normal range of that newer predicted set. So the beauty of the GLI data was not only did it have a more diverse population, not only was it more robust in size, not only did it use appropriate mathematical equations to calculate mean and standard deviation, but it also joined together young people and middle-aged and teenagers and then older people into one predicted set that was available. So if you looked at their original data set, they had 160,000 individuals. It was honed down to about 98,000 individuals. Remind you that we were, prior to this, we're looking at 200 to 300 to 400 individuals. Now we're talking about 100,000 individuals being added into this to describe the various predicteds that were associated with it. And they uniquely identified populations that, based on your ethnicity, there were scientific differences in individuals. So Caucasians from European communities originally, now in America and other parts of the world, had different lung functions based on their chest size than did individuals from Northeast Asia, Southeast Asia, and African Americans. Some of this difference was linked to how tall they were, but there are other differences in between individuals. Certainly, as I look at a large group of populations from Vietnam, the size of your chests are different than my size of my chest, or a European-born individual. That has nothing to do with anything other than you are different, and we all recognize that you are different. Well, this was going along, and we had probably the best in the world, and then a young lady came along by the name of Lundy Brown, who published an article related to that there was racism in the review of lung function data, that racism was the cause of this, and in particular related to Africans and everything. Now, Dr. Braun was an epidemiologist that worked in laboratory medicine, had nothing to do with lung function, but had everything to do with epidemiology. And so her scathing report on this created a cascade of things that took place, and eventually the ATS and CHEST and other individuals came out with articles that supported that maybe we should not look at race as a construct of how we interpret lung function testing, but still stick with gender, because we know scientifically that there's differences in between men and women and the skeleton of men and women and how they are shaped. And so this became, quite a little thing that was going on. And we also had GLI look at it. And what GLI did was they took their original data set, and instead of taking the heavily laden population of Caucasians only, which was a large portion of the data that they had, and smaller portions of the other ethnic groups, let's just take a little from each. So let's just take 25% from here, 25% from here, and then create a reference equation that is more globally based, all right? And so they ended up creating the race-neutral approach to the interpretation of lung function measurements, and what I call the 25% rule, and Professor Land was part of that group initially and included in this publication, but I think if we asked Professor Land, would she use a global approach if she knew the individual that she would applying it to was of Southeast Asian background, she probably would say no, and there's a reason why that is the case. Well, I was part of a group, so there I am. I was a part of a multi-professional group that looked at this question for over a 2-year period and looked at what was available in the references, and essentially what we said is that there is a need that exists for more and better research that would inform our field about the many uncertainties that are out there, and will they serve as a foundation for future recommendations in this area? So essentially, we spent 2 years pulling the data, ended up saying, yes, we understand the science states that there might be differences in different population groups, but we really don't understand the effects of if we used a generalized equation. Well, the American Thoracic Society, 1 week later, published a statement that stated that we should use a global approach and take ethnicity out of the process. But there is a lack of evidence of what would happen if we do that. And so out of our laboratory at the Mayo Clinic, they published this article in the American Journal of Respiratory and Critical Care Medicine, where they went back and retrospectively looked at 110,000 spirometry tests and what would happen if you actually used a global approach. Instead of having a race-specific equation for a very homogenetic population group or someone that self-identifies into one of these groups, we just use that global equation. And what ends up happening is that someone of Asian background, let's choose you as an example, you become sicker, because all of a sudden you're being compared to European-sized chests versus the specific science that we know related to Southeast Asian individuals. And if you're an African American, you become sicker because previously we had very specific equations for you as a group, and all of a sudden you become sicker because you're being compared to a group that includes Northeast Asians and Caucasian individuals. So the impact of this can be associated with what I would call misidentification of an abnormality. In the paper they say, lung function isn't the only criteria that you use to describe a disease process, and I absolutely agree with that. You need a lot of other data to make descriptions of if someone has emphysema or chronic bronchitis or whatever it may be. You need x-ray, you need history, you need exposures, you need all kinds of things to do that. However, if we then take an individual and we put them into a homogenetic category or heterogenetic category, then all of a sudden if you identify as Southeast Asian, you will become sicker. And in order to then further characterize that, it's going to take more resources of doing an x-ray, doing a CT, or whatever that you may not have available to you. So my suggestion is when you're selecting a reference equation that you're going to use, make sure that it's an informed decision, that you are well aware of what you're choosing and the impact of that when you do make a selection. In a very heterogenetic society like America, where we have people from all over the world coming to America, and there may be interracial marriages and children and everything else down from that, I absolutely would support the use of the global equation because we don't know the effect. But if you're coming from a society where we have science that says that based on your ethnicity you are slightly different than other individuals, I would suggest or recommend using those scores. The other thing that we have a problem with and becomes something that you as an interpreter needs to understand is using the lower limit of normal, or a z-score, versus a fixed cut point. Now, one of those initiatives that we looked at earlier, the Global Initiative on Chronic Obstructive Lung Disease, uses a fixed cut point of a ratio of 70 less than 70%. So FEV1 over FVC of less than 70% is considered abnormal. And then you go into various stages or gold stages based on the FEV1 itself and what percent are predicted. So already you can see percent of predicted, what reference equation or category you're putting these individuals in will have an impact on your gold score, right? But you have to remember that gold is there for everyone. And in particular, it is there for primary care physicians to identify whether or not they need to send their patient on to a pulmonologist or a specialist, or identify them as some other thing other than a normal individual. So it's easy for them when they have this plethora of information that they have to remember a ratio less than 70% is an indication of obstruction. The problem with that is, as we see in the article that was published in the Interpretive Strategy, is that the ratio of 70% right here at this horizontal line is really only relative in a very small age group. So someone that's in the 40 years of age to maybe 60 years of age, if their ratio is less than 70%, yes, they have obstruction. The problem is that someone that is very young, they should get more than their air out in the first second as compared to an older individual. So if someone that is very young, their lower limit of normal might be 80% of the air that needs to come out in the first minute or in the first second. And so you're actually underdiagnosing these individuals if you use a 70% cut point. You have false negatives. In an older individual, 80 years of age, their lower limit of normal is substantially less than 70%. So as a pulmonologist group or a physiologist group, you need to understand this. And so as the lungs age, we can blow out less of our air in the first second as compared to our overall values. And so we would have false positives in this group if we use that 70% cut point area. We would say someone has obstruction where it's actually their lower limit of normal. Their results are higher than their lower limit of normal. And in my textbook, I actually characterize this into false positives and false negatives using the NHANES data set that was published, which is a group of about 8,000 individuals, just so you can see what ends up happening with this. In the 2005 interpretation statement, they broke the abnormality grading scores into 5 separate areas. There was no evidence to support why they ended up having 5 different areas of quantifying someone's abnormality. And so when it came to GLI, they actually used the statistical version of what is the lower limit of normal. And so we ended up creating what are Z-scores. And Z-scores are very easy to understand. If we think of Z as nil or Z, it is the median value of any distribution point, right? That is the 0 point. That is the highest point of a population distribution curve. And standard deviations to the left of that are standard deviations away from 0, or a Z-score. If you're using a one-tailed approach, instead of 2 standard deviations being represented by 1.96, 2 standard deviations on a one-tailed approach, what is abnormal is 1.645. So 2 standard deviations away from 0, or a Z-score of minus 1.645, would be outside of what we would consider abnormal. Now remember, the sensitivity of this is based off of kind of a gray area. So if we have 1.645 as z-scores away from the mean, then we end up with areas of uncertainty, because that's the 95th percentile, right? So we still have 5% that may be actually normal, but we don't know. We think that more than likely they are abnormal. So this is the area of uncertainty and or the gray zone, where other types of supportiveness can be very helpful. But what the 2021 interpretive strategy did is that they went down to 3 different quantifications of abnormality. So rather than stating that randomly that this represented a mild or very severe abnormality, they looked at mortality that was associated with it. And so a z-score of minus 1.65 to minus 2.5, there was relatively little difference in between risk of death, and so that was characterized as a mild abnormality. In a z-score that was between minus 2.5 and minus 4, that exhibited a moderate risk of mortality, and a z-score that was greater than minus 4, that represented a relatively high risk of mortality. So how many standard deviations away from 0 was directly linked to your overall mortality or survival based on moderate, mild, or severe classification of that disease. So the interpretive strategy is that if the ratio is low, we have an abnormality, and if the FVC is low, they have possible restriction. They also, if the ratio is normal, they might end up with what is called a non-specific category. What is most often commonly seen in obesity or asthma. This might be also characterized as having a parallel shift in an asthmatic, where you give them a bronchodilator and they have an increase in their overall volumes versus just an increase in their FEV1. So this was originally published out of Mayo Clinic in 2011 in chest, and it looks like this. So if we go to the ratio itself, we have a normal ratio, but we have a reduction in the vital capacity. If we go up and we try and characterize whether or not that's a restrictive pattern, the TLC is actually normal. So then things that we might consider at that point is whether or not we give them a bronchodilator to see if they had a parallel shift. We can also use other types of processes such as specific airways resistance or specific conductance to see if there is an elevation in those parameters to further identify the abnormality itself. I'm going to have to go quite rapidly through these next few slides just because of time limitation, but I will tell you that the bronchodilator response was changed from what historically had been a 12% or 200 mil to a 10% change, but it's based on using the GLI predicted scores and following that as a predicted value related to percent change of 10%. This was significant in the fact that we had used the other cut point criteria since the 1990s, when the original description for spirometry was created. And so it's probably one of the tougher changes that I've heard from colleagues related to the response to a bronchodilator. So if I were to look at this, I take the post-bronchodilator value divided by the pre-bronchodilator value divided by the GLI predicted, and it's going to shift the results a little bit so that what might have been a different change before is different now. And like I said, we just need to pick up the pace a little bit here. The other thing is lung volumes. The measurement of lung volumes, we had a new technical standard related to how we test that was published in 2023, but we also had a GLI publication that came out in 2021 related to what is normal or abnormal. They did put into the title that it is essentially based off of European ancestral individuals. However, the volumes themselves related to RV and FRC are pretty small, so the impact is mainly felt in the vital capacity area as far as characterizing someone as normal or abnormal versus the impact of the FRC and RV values themselves. The good thing is that they did incorporate all the different various methodologies of calculating someone's RV or FRC, being helium dilution, nitrogen washout, or what we call multiple breath washout, and or body plethysmography. So if we go into the lung volume algorithm, it is a very simple, I would call simple assessment, and that is whether or not the TLC is greater than, equal to, or less than the 95th percentile, or minus 1.645. Once we go beyond that, then we just go down the pathway of do they have restriction or do they have other types of abnormalities. Probably the biggest part of this that was new compared to previous is, I'm going to go beyond this here, is the description of either simple restriction or complex restriction. When we think of simple restriction, all the volumes are reduced. So that would be like the small balloon and or the individual that has interstitial lung abnormalities. Complex restriction is more associated with neuromuscular disease or chest wall restriction or occult air trapping. And so once again, Dr. Hyatt, in his later areas of his career, he was one of my mentors because he kept practicing until he was 90 years of age. So that's why I was able to have him as one of my mentors, described in a paper published in Chest as far as simple versus complex restriction. But you end up with larger RVs because of their just inability, their neuromuscular weakness to blow the air out. Diffusing capacity is a pretty easy thing to think about. It helps us characterize what is happening at the alveolar capillary interface or what's happening with gas exchange. This is a cartoon from my textbook that just looks at, what are the impacts of the various diseases on diffusing capacity and or transfer factor as it is described in the European community. Transfer factor or diffusing capacity are just the same process, just described differently. So it's very easy to look at that information. Once again, instead of having populations of 200 or 300 individuals, GLI put out their predicted normals for transfer factor or diffusing capacity of the lung in 2017, where they had almost 10,000 individuals incorporated into this cohort to characterize that. And if you looked at the various authors that were available prior to that, you would see that they were always much higher values than the GLI predicted set, this lower solid line, because the mathematical and statistical significance of a larger data set yielded differences in the lower limit of normal compared to a very small homogenetic data set itself. So the algorithm is pretty simple. It also incorporates the transfer coefficient of the lung, or what we call the KCO value itself, but we are looking at description of what happens to gas exchange at the alveolar capillary interface, and so we end up with diseases like pulmonary hypertension and vasculitis that are differences from just parenchymal lung dysfunction itself. So from this point on, it's who you know, and fortunately we have a lot of great experts that are available to you, and I appreciate the fact of being able to come to Vietnam and share some knowledge related to the interpretation of lung function. But if I had to say one thing in summary, I would say when you're looking at data, always make sure that the data is of good quality. Do not interpret information that is suboptimal or doesn't meet the criteria for acceptability, repeatability, and or usability. The second one is that if the ratio is low, you can all shout it out. The individual has obstruction. And what is low? That means that it's less than the lower limit of normal. There is no percentages associated with it. It is just less than the lower limit of normal. If your vital capacity is reduced, then spirometry suggests restriction, and you need other tests in order to further characterize that abnormality, whether it's present or not. Make sure that you choose your reference sets wisely. And if you have a very homogenetic population like we have in Vietnam, I would highly recommend using either self-declaration and or using the Southeast Asian predicted set that comes from the GLI equation. And finally, diffusion of the lung is an indicator of gas exchange, and there are a variety of things within it that can be very helpful in characterizing an abnormality. And I thank you very much for your time, and open it up. Did you want to do a quick summary then, or do it at the end? Okay, all righty. Any questions at all about that from the individuals that are local? All right.
I think that, do we have any questions online?
No question. Okay, so we have some time to read some summaries of the house.
Okay. All right, that sounds good.
จะไม่เป็นสิ่งที่มีคือเรา